All right, hello and welcome back. I'm Erik, your host of the DocBuddy Journal. Here at DocBuddy, of course, we deliver healthcare solutions that take the pain and cost out of broken workflows, like with OpNotes, which gives ASCs and their affiliated clinics the power of instantly generated operative reports approved from the point of care. You can find out more about that and all of our solutions at DocBuddy.com. And today we've got a couple of really cool guests. We're joined by the host of the newly launched Credentialing Chronicles podcast. We've got Shannen Aguayo and Nyleen Flores.
Woo, woo, woo,
Nyleen,
woo, 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 woo.
hitting milestones before recording too. I won't steal any of your thunder, but a lot of listens happening with just 4 episodes. I know the next one will be publishing soon. But Nyleen, so good to have you back.
Yes,
And Shannen, so nice to have you for the
thank you.
first time.
Thank you. Thank you, Eric. Yes, we're so excited. We've officially hit our 1,500 downloads in
Yes.
less than 3 weeks. So we're so
Yeah.
excited. And you can tell, this really was a necessary outlet that was needed to talk about things that we generally have to keep confidential when we talk about our docs.
Exactly. Yeah, and the funny thing is that we still try to respect the privacy, and so we, always put our disclaimer because medical staff professionals do not play about confidentiality. And so, and we're really good at spilling the tea without spilling the name. So I think that's what we're becoming known for.
Well, I can attest to that firsthand. I have had a riot listening to your shows with just listening to episode 4 before we got together today. So obviously, we need to be sure people can subscribe and like and follow Credentialing Chronicles on your podcast player of choice. Before we talk a little bit more about the show, Shannen, let's start with you. Can you give our listeners a little bit of background on yourself? What led you to this point?
Yes, definitely. I've been in corporate credentialing for over 25 years. About 11 years ago, 12 years ago, I went into consulting with an amazing company down in Austin, Texas, um, and just really learned a lot from her and decided, hey, let me open my own company and do it my way. And so, yeah, we have a NCQA certified credentialing verification organization. It's about to be a woman certified credentialing verification organization any day now. And we just provide credentialing, compliance, payer enrollment, all of that monitoring with a white gloved concierge touch. And so, my people are available 24/7. They're mostly NAM certified. And we just really take care of the providers. If they call us at 11 o'clock at night, we're helping them out.
That's fantastic. And Nyleen, let's give the listeners a quick refresh on your background and then we'll get into it.
Yeah, so I've been in healthcare for about 16 years and I started at the hospital and then got into private practice, ran a nephrology practice for a long time, then got into medical staff. And so right now I am with and finally rebranded my company. It's called Med Elevate Solutions. And so we're providing streamlining services for surgery centers, for private practices, basically looking at their overall practices and assisting them with streamlining and optimizing all kinds of solutions. So DocBuddy is a great help with that. All kinds of solutions so that they can get paid on time, document accordingly, report accordingly, and then also comply with all federal and state regulatory bodies. So
Mhm.
lots going on with me, and then obviously our newest venture, joint venture with Shannen, with Credentialing Chronicles. So lots of fun.
So there's probably no better people on the face of the earth that I could ask this question to then. From my vantage point, credentialing and enrollment are really the first steps of the revenue cycle, right? Like nobody's paying you unless you're on a panel. So with that in mind, what are some of your very best practices for listeners in a credentialing or enrollment sense?
So, for the doctors, obviously, when they get out of medical school, the first thing they have to do is educate themselves in saying that there's two processes that have to go through. They have to go through. They have to go through credentialing, which is an affiliation process to a surgery center, a hospital, of wherever
Mhm.
they're going to seek this thing called privileges. So, which
Mhm.
is basically they're doing what they say they can do and they're going to be verified for that. Then there's another process which uses the same terminology, and that's called credentialing as well. But that is credentialing and enrolling with payers or insurance companies. And unfortunately, that class is not taught in med school. So, and
I
we're
would say one of the best practices that doctors could do, though, is as they're leaving medical school, as they start to leave their residency, start to actually start practicing, maybe keep a, one of those 3-ring binder notebooks. And they could keep all of their certificates in there. They keep their drivers, a picture of their driver's license, any peer references,
mhm,
intern fellowship, hospitals they're with, publications they might have done, different versions of their CV, so that way that we could see like them updating it. Because really, the processes that Nyleen talks about, every one of those documents are going to be needed,
correct.
including some CAQH stuff, and it just is. It becomes like a document torture if we're like, okay, now we need all of these, and he or she was just living their life getting the certificate, some's at my mother's, some's in my storage unit, and then we're like, well, we kind of need those, especially when they're starting to get on panels, credential with hospitals, different things of that nature.
Right.
Well, what I wanted to ask there too, I know it's a very paperwork intensive process. A lot of effort can go into compiling that binder. How often does somebody hand you their binder and go, "Help me out with this carrier, and this carrier, please"? That's gotta
That
never
that
happen.
that would be never. Never have I been handed a binder. I say this advice all the time, right, Nyleen? I mean, I know you do too, right?
Mhm.
But never have we been handled, a binder. At AQC, we have a process called like a self credentialing, where some of the providers that are just tired of looking for everything, we kind of compress it all into one, and then we kind of re-credential them every 2 or 3 years and give them all their documents, and then they could just hand that binder to their hospitals, to their people, and that makes those providers very, very happy, because everything is verified and complete, and the medical staff professionals love that as well, because they don't have to always go back. And so that's type of like a self credentialing that they do.
Yes, and there's also platforms on there. And so there's platforms, obviously, like in the state of Florida, there's CE Broker. I'm not even sure if that's a
Mhm.
Florida thing or a national thing, to be honest with you, full disclosure, but that's where they keep all their CMEs in one
Yeah.
area. So there's a platform that came out, and it's called Mockingbird. And so what they do is they basically keep everything, including CMEs, in like a
I've heard
file.
of them. Yeah.
So the doctors can upload all that information, because on top of that, they're going to need to put all that information in this thing called CAQH, which is
Hmm.
like an online repository that the insurance companies go to collect the data, to get like the copies of their certificates, the copies of their licenses. So they do have to keep an online version as well. What happens with the binder, which is why we as medical staff professionals always say keep a binder, is because the paper is always better,
Hmm.
because you can always lose a digital file or have your hard drive crash like mine did, and then you lose everything. So the
Hmm.
paper is always best. And then you would have to hand that either to each facility you go to for that privileging process, or to the insurance companies, or a CVO, which is what Shannen has, is a centralized verification organization that kind of does
Hmm.
all that different types of credentialing for you.
Sure.
Hmm.
So it sounds like one of the ways people can really make it hard on themselves is not knowing where all these documents exist or not
Hmm.
having access to the digital version of
Hmm.
them.
Yes,
Hmm.
and it starts with them graduating with like their college degree, and then
Yeah, their med degree. Yeah, yeah, yeah.
their med
And
school.
I mean, when you talk about pitfalls, Eric, right? That's the number one.
Yeah.
The another big one is, not being available for signatures. I mean, nowadays, after COVID, thank God, a lot of the electronic signatures are accepted by everybody. But back in the day, you actually had to get those live signatures in black or blue ink, and that was so hard. But even now, some of the oh, I didn't get it. I don't know how to do it, and so you're like, oh, let me walk you through, sir. Or ma'am, let me get you through this signing of a document.
Yeah, here's how you do it. You uncap the pen,
Yeah,
or if
yeah.
you use
You
DocuSign.
press start right there at the DocuSign. Yeah, yeah.
So then, with the last presidential election, this isn't a political show, but just discourse on the industry. Has there been anything that changed with the new administration and a different looking Congress in terms of credentialing in 2025, or is there anything new for this year unrelated to the elections last year that people need to look out for?
Well, I think that I'm sorry, Nyleen. Do you want me to take it, or you want to take it
Yeah, go
beautiful?
ahead. Go ahead.
Okay. I think really credentialing doesn't become affected by the political change in office. I think sometimes the plans do. So, some of the Medicaid, Medicare Advantage plans, the plans under it, the
Sure.
carved out plans, yeah, those do because they change. When Obamacare came in, a lot of plans changed, and then the doctors have to get recredentialed, and it's this huge thing, and the patients have to be, moved to that plan. But I think as far as what we're talking about, as far as credentialing with an affiliation or credentialing with a health plan, those things really don't change. But what does change is our standards, accreditation standards change. So a big one of that is the NCQA. In your system, in your field, the AAA-HC, and they are the ones that put out the standards. And so they're the ones that say, we want a CV in month year format. And when we're auditing you, that's how we want to see that CV. And so when Susie is in the office saying, Dr. Smith, I know this is your CV for 19,000 years, but I have to have it changed in the format. We really can't be mad at Susie because it's being asked for on an accreditation level, and so I think that's something to just kind of understand that timelines change right now. NCQA has huge timeline changes coming out. And so where things used to be able, a doctor used to be able to sign an application and that application would be able to sit for a year and or be processed out for 365 days. Well, now they're shortening it. So it then shorted to 180. Now organizations are 120 and CVOs like myself are now 90 days. And so from the time that the provider signs the release to say, yes, credential me, to the time that the actual client gets back the file, we only have 90 days to do that. AQC tries to get it done in 30 to 40 days. So we're way above that. But I mean, it things like that do change, we're having to put more pressure on providers to say, get these things done.
Yeah, and you really, it sounds like you really have to navigate a bureaucracy to get it right, or know how to navigate
Yes,
that
sir.
bureaucracy.
Yes, sir.
Well, I appreciate the display of expertise there, ladies. I want to get you kind of into your natural elements, what people can get more of on Credentialing Chronicles. So I know there will be a couple of these that come to mind, and certainly don't steal any of your own thunder. But I got to ask, what are some of the wilder, either the funniest or the scariest sort of credentialing stories that you've been a part of, heard of? There's got to be some good ones out there.
Well, our disclaimer says we don't talk about the people that we've credentialed, but since we're not on Credentialing Chronicles right
Yeah, I was
now,
gonna say we're
and
not
we're
on
on
our show,
DocBuddy,
Nyleen. You can spill a little tea for Eric. Come
I'll,
on.
I'll spill a little thing. I do want to ask though, with your experience, and this can just launch into like the tea that we need to talk about. In your experience with DocBuddy and having doctors quote unquote complete op notes. Have you ever questioned, is this really a doctor because the op note is like so bad?
I need to give you. There's two versions to this answer. That DocBuddy obviously takes access and controls very seriously, and we have policies and procedures in place to prevent the completion of operative reports by those that are not authorized to do so.
Okay.
However,
Uh-huh.
we're not in control of everything that happens in the world, and kind of on this in this same vein, for maybe the less sophisticated facility that isn't as concerned with adhering to compliance
Hmm.
or the law.
Say
Right.
that again,
Do
Eric.
you do you have a function that would allow my providers, that would allow my surgeons to batch complete all their op reports for a week or two? And the answer is no, we don't.
And you
And
shouldn't.
we're going to pretend that you didn't ask us that,
Yeah.
Hmm.
but the answer is no. They will need to review them one by one.
Hmm.
So, Nyleen, I'll have to come on your show, your guys' show, to spill my own tea. But that is my answer. We take access
He
very
said he ain't
seriously.
giving us no more tea, Nyleen. That's what that
No.
means.
Yeah, exactly.
Use of our software.
So, okay, so crazy stories. I have had everything from a a neurosurgeon committing suicide in a bathtub in his parents' house,
Mm.
to one jumping off of a ledge, to one being found in a closet with a needle in his arm,
Ooh.
to a electrophysiologist asking for privileges in a procedure she's never done in, well, she hasn't done in over 7 years and had to tell her no. I have had ooh, uh, a doctor who was actively sexually harassing, and the nurses refused to say anything for many years until finally action was taken. I've had somebody impersonating a surgical assistant in the operating room that we had to physically remove from the operating room after somebody Googled them and found out that they weren't an actual surgical assistant.
Poor Eric's face. Eric, do you really want to know the tea? Are you being burned over there?
No, no, I don't. I don't want to. I don't want to take the air out of the room, but I do want to, call this out that we recently had Dr. Steph Simmons, who's the CMO of the Dr. Lorna Breen Heroes Foundation, on our show in
Yes,
the last couple of episodes, destigmatizing providers seeking mental health. Kind of right up your alley because they do a lot around
yes.
legislation,
Which that is
credentialing.
a beautiful story, the whole Lorna Breen, because it's really sad. She was really, really needing help, and unfortunately, she fell to the problem of COVID. But burnout is real, and the thing is doctors are held to an above normal standard, and then at the same time, it's the they're just it's just it's just so hard. It's so different. Doctors, DUIs. Is your pediatrician arrested with a DUI? Do you continue having your child see that pediatrician? Like, this is real stuff that dealt with on a day to day basis. Lying, they had a $5 million lawsuit they never disclosed. Um, I mean, I could just keep going on and on and on.
Yeah, and I think that the system that is now in place perpetuates these type of bad actors to continue because there are levels of protections by facilities, by the state board. Um, all of the due diligence that could be done is not done sometimes. And it's because people don't, at the very high level, do not want full transparency on
Mhm.
their providers because I think, like me and Nyleen have discovered, it provides a shortage of then providers. And
Oh
what
yeah.
do? If you don't have the providers to do the job because your bylaws says that if you have sexually assaulted somebody in the last 5 years that you cannot work at their facility, and then your provider comes back and they are sexually assaulting somebody, what do we do?
And
And that's really what the problem is, to be honest with you, is that I think
mhm.
that there's so much going on that people just do not want transparency.
And the financial impacts. So we all
Hmm.
know, especially in surgery centers, money is the issue, right? And we all know when you're trying to sell your product, it's the money. It comes down to the bottom line because surgery centers are making half of what a hospital is making. So this is why it's a push through. So I may or may not know somewhere that is a surgery center who is may or may not allowing someone who may or may not be sanctioned in over 5 states and has, you know, hurt multiple people, because they're just like, we just need the revenue. We need the cases. We don't have a choice. I have to let them on staff. And I'm like screaming at the top of my lungs. But at the end of the day, what are you going to do? You
If
know?
somebody gets hurt. Hmm.
And then, but you're going to pay for it now or you're going to pay for it later. I
Hmm.
mean, that's just my perspective.
And
But
and I think there just needs to be a new, I think a new fresh air in the thought process, to be honest, Eric, because doctors are graduating every day, and they say that there's a huge shortage here and there's a huge shortage there, and so it's if we allow these type of practices to continue, then the new doctors that are coming out fall into being vulnerable to these situations as well, and then it just creates an even more non-transparent system. And so we just really advocate that each facility can be as transparent as they want to be in their credentialing bylaws and credentialing manuals, and we advocate that they should be.
yeah,
Well, I think Nyleen raised an interesting point there. Either pay now in the specific
Hmm.
hypothetical example, yes, you will not be able to handle those cases, but imagine the liability you're undertaking by allowing this provider to continue practicing against your own bylaws. And at some point, somebody's going to find out, or somebody will be,
Hurt.
God forbid, hurt so badly that everybody will find out.
Hmm.
Hmm.
Look at Dr. Death situation. I mean, that's exactly what happened.
Yeah. Yeah, you're totally right.
Hmm.
Episode 4 of
Hmm.
Credentialing Chronicles. You can hear all about it.
Yeah. Yeah. So there's a lot. And then we also don't want to lose sight of our wonderful physicians. And it gives them a bad name, you know. This is the
Hmm.
whole stereotypes, you know, where people make, you know, certain races and they make fun of, you know, these people are this and these people are that, or even if in our own country, oh, people from the south are this, or people from the north are this. And so we make these generalizations and that's not always fair. So same thing is while we are exposing all of these things, we do recognize that there are amazing physicians. And so those amazing physicians should stand up for themselves. And if they see something, you know, in Dr. Judd's situation, just to talk about that for a second, it was a physician who finally put his foot down.
Hmm.
And
Hmm.
so those are the doctors we need. We need good doctors to say, hey guys, this is not right, you
Yeah,
know?
we have a PSA, segment in every episode, and that's what we talk about. Doctors, if you see something, it's okay to go to your medical director or your medical staff office and say something in private, in confidential. It will not be talked about. You won't hear that it's from you, and we're just trying to really empower people that are in these environments to be more vocal, and just really protect patient lives. And then on the offensive side, we're trying to empower patients. Patients are not taught that they can go to the medical boards and verify their doctors for free or set up a Google alert to see if their doctor comes out on the news because he or she has been drunk driving or just found on 100 counts of child pornography. I mean, there are so many things that come out and you just don't know until it comes out. And then it's what we always talk about, a pattern of behavior. It's been happening for years. That's what they always say. It's 10 years, it's been ongoing.
Well, physician, mid-level, anybody in a medical organization, like as you say, if you see something, you should say something.
Yes.
But that's true for all professions.
Yes.
Medicine's a little different because you have patient lives in the balance at times, or you're caring for people, so it is a little bit different, and they should, in my view, be held to a slightly higher standard. But right is right and wrong is wrong.
Yes.
That shouldn't be tolerated.
If they could say something on the subway. I mean, why are we not saying that in healthcare or in any other profession, like you're saying, Erik?
Hmm.
Yeah, I'm gonna butcher the phrase if I try to give it to you off the top of my head, but it's, evil doesn't triumph because good isn't strong enough. It's because nobody does anything
Mm-hmm.
about it.
Mm-hmm. Yep. Exactly.
Hmm.
Well, for how about a little levity, because that got a little heavy, and I do want to take a quick
Sorry.
aside here that if you are in medicine, whether you're a provider or otherwise, and you are not feeling well, go get the help that you need. And Dr. Lauren Breen Heroes Foundation is there to provide resources to you. I mean, that is a really serious topic, and unfortunately, we've seen the loss of some of our surgeon clients over the last 2 years to their own hand, and it's a tragedy. You don't want to say it's preventable. People will make their own choices, but
Mm-hmm.
heavy stuff.
Yeah, I think, but the good thing is that in transparency, helps good be identified, excellence be identified, and it also helps things that shouldn't be happening be identified. And so, I think transparency is just something that has been lacking from credentialing, since it came into existence and was part of legislation. And I think now just our podcast is just kind of shining a light on it, and people are saying, oh, I've been asked to falsify audits or this, I've had to quit, I went into a new profession. I mean, you really don't understand the types of messages we have been getting since we started this podcast. And it just goes to, like, we have needed to do this. Like, this is something that needs to be talked about. I think there's a lot of confusion around credentialing.
Yeah, I'm glad you're doing it. I'm glad that platform exists, and
Thank you,
for
Erik.
that a little bit of levity that I owe our listeners and owe you too. Um, many years ago, I worked at a pure revenue cycle vendor here in Miami, and credentialing was a part of the services offered. So this is just shortly after COVID, and down here in Miami, we had a pandemic for all of about 90 days, and then
Okay.
Pretty much.
everything
Pretty much.
went back to normal, and
Yeah, yeah.
no big deal. But Miami's kind of a different place compared to a lot of the U.S. So coming back to the office that June
Okay.
and overseeing the sales organization, I ended up fielding a lot of calls from our corporate office from providers that I want to open a COVID lab. Can you do my credentialing?
Mm-hmm.
Like, okay, is this like part of your practice, or is this a new tax ID that we're talking about here? Oh yeah, it's a new one. It's not part of my practice at all. And the the letdown of so many individuals hoping to open their COVID lab put me at the end of the wrong end of the screaming match. What do you mean United said they have enough COVID labs? Like, this is outrageous. I've been in practice for so long. Call them again, call them again, call them again. No, we don't need 25 COVID labs on every block, in June of 2020 or whatever it was.
Mm-hmm.
Mhm.
Mm-hmm.
So what are some screaming matches maybe you've got to have at the expense of a payer to get somebody credentialed and enrolled, or what's maybe some heightened interactions that you can share with our listeners?
Yeah, I mean, I could tell you a good positive story. I love positivity, Erik.
Me
um,
too.
we are big advocates of sending, enrollment people, managers. We'll send you a pizza. We'll send some DoorDash lunch orders over if we can get an effective date a little sooner. I'll send you. Do you need an edible arrangement? Do you feel like a little cantaloupe? I will send that over to you. And so, I mean, thank you. Thank you for making sure that this clinic, this organization, I work with a lot of FQHCs, and we do that a lot for the FQHCs because it's so important for them to, be in the panels. And so, yeah, we will just, I try not to get into screaming matches because you get way more accomplished with honey than vinegar. And so, that is something, a little trick of the trade I'll disclose to y'all.
So
There you go.
Shannon
You're right.
Shannon is the sweet one. I'm
Yeah.
the I'm the Florida girl. So let's talk about Florida.
Nyleen don't play.
I don't play. I have no patience. I'm so
Yeah.
sorry. That is my absolute downfall. So the problem with a place like Florida, Erik, is that it's oversaturated. That is
Mhm.
different from a FQHC or a rural facility. When I moved to Georgia, I got on the panels within 30 days. But that's because there was no other hand surgeon in a 60-mile radius. So the
Mhm.
panel said, "Oh, great, you're a new
We
doctor. Let
need
me look
you.
at your
Yeah.
zip code. We need you, no problem. Here's your contract." Not the case in Florida. Had a primary care clinic I opened, and it's years. And they're like, panel is closed, panel is closed, panel is closed. So at that point, you just get into an endless cycle because they're saying there's, like you said, too much in this zip code. So if there's 25, 27, 100 primary care providers in this particular zip code, they're going to close the panel. And so at that point, it's you having to prove why your service line is different.
Why you're
It is
special. Yeah.
why you're special. So that is, and it's not winnable. I mean, it's just standing in a queue and just keep trying to try. Huge problem is anesthesia. Anesthesia to get in network is near impossible. It is extremely difficult in a high density area like Miami, like Naples, like Tampa. They're just so overly saturated, and I really don't think they take into consideration the population of people. They just take into consideration the number of providers in that particular zip code.
And how
Whi-
how often do they even update that, right?
Right. And then you can keep asking. So they'll just tell you reapply in X number of months. And so then
Yep.
you have to reapply and resubmit and request and redo and repair. And then that's not even getting into the contracting issue. Why is healthcare the only business where somebody else, a third party, it tells you what you're allowed to make? That is so not fair. So
No.
not only that, right now I'm in a screaming match right now with with a payer in Georgia, and I'm telling them they're like, no, we're gonna pay you. Check this out. She started at 80% of Medicare. I'm like,
Oh,
why would I accept that? I'm like, no, I need more. She comes back, she counters 88% of Medicare. So it's like so when that is a screaming match of like, we're
Hmm.
not going to accept this. My doctor is worth more. And so
Yeah.
all of that is time. You can't treat the patients. And in the meantime, patients don't know, they don't know that I
Hmm.
can make $5,000 for the surgery versus with this insurance, but yet United Healthcare is only willing to pay me $300.
Hmm.
Right.
So
Exactly.
that's where the screaming match. It's the only business where somebody else decides what you are entitled to get paid or what you are worth. You don't get to choose that, even though you're the one selling the product, which is the healthcare. So,
Yeah, I'm having an issue with that exact happening too with some physical therapists up in Pennsylvania. They do the electrical, procedure, and they're all board
Mhm.
certified. They do this, and they want to pay them $78, and I think
mhm,
the payment is actually like 324. But they're saying because they're physical therapists, and they're saying, well, no, we're board certified. No, we just want to pay neurologists this. I mean, it's just crazy. And so, yeah, I am actually going through that right now. If I just try not to get to a point of screaming, I'm like, are you hungry? Are you not happy? What can we do, to make you happy and then make you do
I
the
need
right
to
thing?
learn from you.
I just want to make this work, ma'am. Okay. We're all in this together. That's where I come
Yeah.
from.
Nobody really wins with the screaming match, but unfortunately, sometimes
Yeah.
you have
Yeah.
to resort to it. It can sometimes be the right thing, even if it's still the
You're
wrong
right.
thing.
You're right.
Well, let's talk about the payers a little bit more. Let's sharpen our spears a little bit because at some point there will be a reckoning. I don't know what that will be, and certainly not advocating for any sort of physical reckoning, but more regulatory.
Hmm.
As Nyleen, you point out, we'll pay you some percentage less than 100 of Medicare. Like what? Medicare rates just dropped. I'm X specialty. They're already paying me 9% less this year. Like I'm going to get a proportion of that
Yep.
Mhm,
from a private carrier. Like I don't think so.
mhm.
How do we fix this three-legged stool where there's really only one leg on the patient, provider, and payer stool that seems to matter?
Well, I think the first thing is, a paper trail. And talking to the provider reps in the area in charge of the contracting process, and then once you get their initial offer, submitting some negotiation paperwork, and you're really trying to keep a paper trail and saying, look, this is like Nyleen said, this is what makes me special. This is, which is kind of sad, right? It's like you went through all this schooling, you should be able to see insurances, and it's like now you have to play this game of I'm special, pick me, and that's very hard to do for providers. And I think sometimes they get very upset because they don't understand that that is the game that they're asking us to play. Right,
Mhm.
Nyleen?
Yeah.
What do you think, love?
Yeah. Yeah, and I don't know because it's controlled by people with a lot of money with
Yeah.
e- every other ulterior motive other than helping the patient.
Hmm.
How is it possible that you tell me my person who has a meniscal tear that's been diagnosed by an MRI, the entire thing is completely frayed. The person cannot walk. And you mean to tell me I have to send them to 6 weeks of therapy to make the injury worse, put the patient in pain, have them spend more money before you'll approve an MRI? Like,
Yeah.
I I have 8 patients that were just denied last week. Eight. Eight.
And then
Well,
and then you have some of the doctors that are employed by the insurance companies, and they're employed to look at these cases and deny them.
mhm,
And so, I mean, that is who's looking at it, right? And so
mhm.
you have to think, maybe the doctor should say, no, I don't want to work for your insurance company because ultimately I want to help people, because that's who's
Well,
looking.
to that point in this orthopedic example that Nyleen painted for us, the odds are it's not an orthopedist
Mhm.
reviewing that case.
Yeah,
It
exactly.
could be an
It's not,
ophthalmologist.
because it would be too much money to pay one.
Well, and we love our retina docs, but
Yeah.
last time they were reviewing an orthopedic case was in medical school. What
And
what
I
makes
think
this?
unfortunately, some people will say anything, for if the dollar is great enough. I'm sorry, but I do feel like that.
That's true. That seems like a pretty easy fix. I'm not here to advocate for a stroke of a pen, law fixing things when the market maybe should do a better job of fixing it
Hmm.
itself. But this seems like a really easy one just to go, you know what? If it's this type of a case, then I need this type of doctor reviewing it.
To
Well,
review
Not
it.
somebody.
Exactly.
right. And in TikTok and in Instagram, there's these great doctors that I absolutely love to follow because they're bringing it out to light, and they are
Mhm.
physicians who are absolutely trying to help patients.
Yeah.
And the one particular breast surgeon, she breaks my heart because she was literally crying on there. She was
Yes.
like, "My patient has cancer. My
Yes.
patient needs a
And we
mastectomy."
were just denied and taken out of
And we were
surgery.
just
Yep.
denied. She's like,
Mhm.
I'm literally have the knife in my hand and they
Yeah.
pulled me out because United decided to not approve the surgery.
Or the
And so,
surgery ran too long.
or the surgery ran too long. I
Mhm.
mean, that is, the doctors are not allowed to practice medicine,
Yeah.
basically.
At that point, it is not medicine that is being
Mm-mm,
practiced. Yeah.
mm-mm,
There's no
Yeah.
love, there's no compassion, and they're taking all of those things out of it, and it's all
mm-mm.
becoming about money. And unfortunately, that's why the medical staff professionals are so important because they keep the human side of it in, and they are the ones that are the gatekeepers of patient safety. And they're the ones that say, look, this doctor just came out. They haven't done but one case. I have the case logs right here. I cannot grant privileges because the bylaws don't allow me to, and holding that
Yeah.
firm and not saying, yeah, let's just do it.
Yeah,
Well, Shannon, the example you just brought up that the procedure was going to be too long. I think that's if we're matching up on the headlines here. It
Yeah.
wasn't. It was that the anesthesia portion. They wouldn't approve the anesthesia for the full duration of the
Yep.
surgery. So it's like you can have anesthesia for a third of your procedure. Like,
Yeah.
no, I need it for 110% of my procedure. Thank
Exactly.
you.
yeah.
Does that even make sense? Yeah.
It actually passed in 2 states, and then after the uproar, it was taken back. But the fact that it even got through some states was abominable.
But
Uh,
again, that's the transparency now, right? Where a doctor didn't have that available to step on TikTok and say, look what is happening in real life, in real time. And I think, again, that's what Credentialing Chronicles is doing, is like, we want to keep the line live about what is happening and allowing people to see they are on alert. They need to stay on alert. Patients need to be on alert. Doctors need to be on alert. MSPs need to be on alert because there are people out there trying to do bad things.
yeah.
Thank you, Nyleen.
I-
I just wanted to let that breathe a little bit because there are certainly folks out not for the best interest of the patient,
Mhm.
but in my experience, for the most part, providers are, doctors are, and
Absolutely.
Yes.
there's
Yes.
some bad apples we
It,
can
it,
hear
it's
all about.
it's 230 files. Good, great, amazing doctors. And the 231st file is somebody with 99 sanctions.
Right.
Yeah. So no, it's not. We're not. We Nyleen always says this. We always say we love doctors, APRNs, PAs. We need them. They are amazing healers, heroes. But on the other hand, we need to protect the good ones, because if we allow bad people in there to just run amok and not be identified and say, look for these signs and not learn from our mistakes, then we're not protecting the good doctors either.
Right.
Sure. This is good. Flashing back to our last topic just a little bit. 2 years ago, around January timeframe, there was this really long Twitter thread posted around the this is healthcare's top deck of the sinking Titanic moment. This is when things like ChatGPT were fairly new or becoming more prominent, and the thesis was that the traditional pay for insurance, whether you get it from your employer, whether you get it yourself, that this model was going to go away because there is this parallel world starting where it's all cash for service, regardless of what it is. Simple primary care visit that already kind of happens, right? With minute clinics
Mhm.
and your walk-in type
Yep.
places. Nyleen, I see you going. Give me just a
The
second. I'll
online.
tee up here.
Mhm.
But the issue in this thesis that I saw was that you cannot have an LLM like Chat GPT or Claude or pick whichever one you like, intaking a bunch of patient information, spitting out a diagnosis, and having a physician sitting at his desk stamping prescriptions or approving orders to do the next piece of care or whatever. But with how little the average healthcare consumer gets from their insurance, I think it's going to become more of a reality, at least in parts, in the near term than maybe I initially thought seeing this thesis. So, do you have any thoughts on that?
Well, I am providing healthcare setting in that providing healthcare setting every day. And AI is enormously assisting physicians to the point that you allow it to. It can take over. I get reached out to by a lot of AI companies that are looking to fully automate. There are EHR systems that use AI robots to quote unquote screen the documentation and automatically provide an E&M, or it's called an evaluation and management level of service that was provided to the patient. And then in turn, the insurance companies are using their robots to screen, and they'll say, this provider submitted this many level 4 claims. Oh, we're going to deny 50% of them because we say it's not enough. So I have had multiple claims denied by a robot because obviously all the criteria was met. Um, but the robot decided that we did not meet the level of service. And so they asked me to resubmit a claim with a lower level of service. The insurance company robot did that. So AI is already real and it's already being used in healthcare to adversely affect the physician, which leads to disgruntled physicians and obviously a continued ongoing loss of revenue. So, that being said, we use a AI robot now currently with our current software, and what it does is it turns on when the physician walks into the room and it listens to the conversation. What I will tell you, it's really good because it documents what the patient said and it transcribes it. It will put it to where it goes into the system. It's not flawless. Some words with certain accents are not interpreted and typed in correctly, so they do have to be reviewed. But it's extremely helpful in streamlining the documentation um, into the EHR. So it's what you said, just a little bit. The doctor is walking in and actually seeing the patient and it's documenting it.
Sure.
The feedback from the physician is that it is extremely helpful and it's a lot cheaper than hiring a scribe, because a scribe you have to pay hourly benefits and hourly wage and benefits and stuff like that. So it replaces the need for a scribe to walk and shadow a doctor into the room, and it allows the physician to talk to the patient instead of the computer. So it allows them to examine the patient. So the what we can assist, it also helps is when the medical assistant goes in there, the robot turns on and the medical assistant will go and says, okay, can you tell me how many surgeries have you had? And then they'll go in, I had my gallbladder removed, I had my knee surgery, I had my shoulder done, I had my adenoids removed. And then the robot will type it into the surgery history and you just have to move it into that. So that is extremely helpful because you do have to meet certain qualifications to meet the level of service, even though.
Sure.
So I wouldn't say it's all bad. It is good, but it does require a human. I am against automatic coding currently.
I'm with you. And as a quick aside, and Shannon, I'll turn it over to you here in a second. I know we're getting close to the end of our time together, but what you just said about the auto denial, like, oh, this guy he can't have this many level 4 visits, even if the documentation bears it out, even if in the contract, this is what we define a level 4 visit as.
They will still
And
deny.
this prior guest of the show, also an orthopedic surgeon, a lot of folks to treat here in Miami for their knees and hips and elbows. He turned to an LLM to produce really succinct documentation summaries to go, here's where your contract says this is a level 4. Here's my documentation that matches right up with what you sent me. Here is a source from a medical book, and you're paying it, baby, or you could talk to my lawyer, period.
Did
So
they
I thought that was
pay?
pretty clever. Yeah, oh yeah.
Good.
He has less problems with that payer after, the barrage of
But
LLM
but that's what I
generated.
think, right? When you ask me, that's what I think. I think that AI is as useful as it can be, but you always need a human there to kind of check, because I can't even use talk to text without it telling, I just the most craziest bizarre story to my daughter, and I'm like, I swear that's not what I said. So I mean, and I push send. I have full confidence in that talk to text because I talk very clearly, but the story that they have now transcribed to my daughter is just crazy. And so I'm
Sure.
like, okay, Yeah, if talks to text cannot be at 100% workable, I'm not going to trust it, in credentialing, in compliance, But yes, it is a great tool. A medical staff person needs to know what exactly is the standard for privileges for orthopedic surgeon. Yes, use ChatGTP and then look it up and see what they say and verify it with two or three other sources. And yes, you might be able to get these privileges approved through your committee, because you did a great job and you use that as a resource. But I think actually depending upon that, like the web crawlers and things that you see in credentialing, we have clients that trust these big software companies and everything that they say, and they leave them and come to us and say, they weren't able to do everything that they said. And I think it's just better if we have a team like yours that can do it. And so I'm like, yes, let's do that. And so I just think that it is very useful, but I think that it does not omit humans from the process.
No, I mean it's a very much an in-person practice of medicine. Just to close the loop on that top deck of the Titanic moment, I thought a lot of it was really hopeful, and hopeful in a way that maybe there would be a lot less lawyers practicing in the medical field as well, and a lot less
No,
compliance.
definitely not.
And that's
There's
tongue in
more.
cheek. That's, that isn't going to go away, and probably for some good reason too. Love all our
Yeah,
lawyers
yeah.
in the medical field out there, but the other half of that, though, is that because patients get so little from their private insurance now, maybe there will be a new bloom of more concierge medicine, specialties, cash pay surgeries, which you need, would need the surgery center to accommodate, as opposed to hoping to book your own room at the hospital for your left total knee, which hate to come out of pocket for that.
Well, the people, now are really even considering, should I get my medical treatment done in the United States, or should I go to Turkey or Dubai, or what do they call
Yeah.
it? Medical traveling, that is like literally a term now. And so that's kind of scary too. When United States used to produce the best doctors. And so, it's just things like that, we have to think about. Like, we outsourced everything to China. Now everything's made in China. Now people are mad, now, like, we're like, we can't even make cars anymore. And it's like, we can't do that to medicine with these patients' lives, and then just say, oh, sorry, there was things that went wrong. Because, being in credentialing, I will always advocate for patients.
Love that. Well, ladies, let's let the listeners know where they can get more of you. How can somebody listen to Credentialing Chronicles?
Do it, Nyleen. You do. I love listening to you.
Credentialing Chronicles. It's now available on all your podcasting platforms, available on Apple, Spotify, Amazon, YouTube, or videos are the videos, not the audio. We're not on video just yet. Working on that. Um, I know, Eric, you told me that. They can listen to us on YouTube, subscribe, and follow our website. They can also just log on to our website, credentialingchronicles.com. Episodes are posted right on there as well as all of our teasers, all of the releases we publish every Tuesday at
Yep.
midnight. And so available for all. We love to hear you. We have so much more to discuss, and we're having a blast. So
Yeah, and I think we started with doctors. We had to start with the good gossip. But we're going more into giving some accreditation gossip, some facility gossip, surgery center gossip. I mean, Eileen has pages and pages of surgery center gossip.
yeah.
And so, we're trying to get into more every area of healthcare, and not just kind of focusing on doctors, because we don't, I think we're what, 13 episodes in right now,
Yeah.
as far as our recording, and they're all about either dentists, doctors, nurse practitioners. So I'm like, I think we need to start talking about some facilities and the things that they do. So it's going to be everybody. We got a lot of gossip.
Hmm.
Well, I hope I can get an invite. I've got a couple, maybe a little bit of tea, maybe not as hot as your tea, but being a door-to-door medical software sales guy once upon a time, I had some interactions I won't forget anytime soon. I'll leave it at that. We'll
Don't
see
play
if I
with
get
us,
the invite
Eric,
to
because if
Credentialing
we bring you
Chronicles.
on, you got to start spilling.
Yes.
Okay. Yeah,
Yes.
Okay.
we're past the statute of limitations on some of these. So,
Yes.
All right. Thank you so much,
well,
Eric.
Thank
We
you
want to
so
thank
much.
you both,
Eric,
Nyleen,
DocBuddy, we
Shannon.
appreciate you guys so much for supporting us.
This has been a riot. You've got a standing invite to come back, obviously. And for our listeners, we want to thank you for listening on behalf of the entire DocBuddy team. Be sure you're subscribed to both Credentialing Chronicles and the DocBuddy Journal on Apple Pods, Spotify, and YouTube, so you always get the newest episodes of the show. And until next time, I'm your host, Erik. We'll talk to you soon.